Welcome to Ageless and Outrageous, your favorite podcast about how to age amazingly. I'm urogynecologist and hormone and sexual health expert, Dr. Kristin Jackson. Every week, I share my over 25 years experience to guide both men and women as they age. Listen as I discuss a variety of topics, including hormone optimization, pelvic floor health, maintaining a vibrant sex life, weight gain issues, and skin, hair, and body changes as we age. It's happening to all of us, so listen for some solid scientific knowledge on how to handle these changes. Tune in for a dose of laughter, knowledge, and an honest perspective on the incredible adventure of growing older. I want to talk today about a study that came out last year talking about two things that I think are critical, and those two things are testosterone and mood. In my clinic, I am always talking to patients in midlife and beyond who complain of feeling like they're just not themselves. They're depressed, they're irritable, they're snapping at everyone, and this is not their norm. These are all called mood or cognitive symptoms. And if you go to your primary care and you complain about these symptoms, I can't remember the words when I'm thinking, I don't have the recall I once had, my concentration is all mushy. Sometimes they call this brain fog. Very often, you're going to be diagnosed with depression or anxiety and likely started on an antidepressant or an anti-anxiety medication. And I'm not necessarily saying that's wrong, but I might say that that is the only way your primary care physician was trained to deal with mood and cognition symptoms. They probably received no training at all on how to think about your hormones, specifically testosterone, in relation to your mood complaints. And generally, when I bring up testosterone to either patients or even other physicians, the first thing that I hear is that there's no data about the use of testosterone in women, and that's simply not true. We do have a lot more data about testosterone use in men. There's less data on testosterone use in women, but it is out there and it is reassuring, because most of that data shows minimal, if any, risk at all for using testosterone in women. And it's important to differentiate the risks of using a medication with side effects. Risks are things that are harmful to you, like increasing your risk of heart attack or cancer or stroke. Side effects are things that we kind of expect to happen in a certain percentage of patients simply based on the way the medication works. A great example of that is the bladder medications that I prescribe every day. A lot of these medications are in the family called antimuscarinics, which means they go to a receptor in our body called the muscarinic receptor, and they block it. There are muscarinic receptors on our bladder, and when we block those receptors, the bladder can't squeeze or spasm as strongly as it used to. Therefore, patients feel less urgency, less frequency, and have less leakage. Unfortunately, there are also muscarinic receptors in our eyes, in our mouth, and in our GI system. And the drug is not selective to those, so it's going to block the receptors there as well, which means we might also notice some dry eyes, dry mouth, and constipation when we use these medications. Dry eyes, dry mouth, and constipations are not risks to taking the antimuscarinic medications. They're side effects. We know that they are going to occur in a certain percentage of patients. It's not surprising to me when they occur because that's how the medication works. And that's really what I see with the data on testosterone. We know how testosterone works in both the male and the female body. There are testosterone receptors all over from head to toe. And when we stimulate those receptors by giving either natural testosterone from your ovaries or testes, or bioidentical testosterone from a cream or a patch or a pellet, it's going to stimulate the receptors in the same way, and we're going to have the same effects and the same side effects. But the risks, the dangerous risks, are really very minimal, if any at all. Because remember, testosterone is a human hormone. It's not a male hormone. It exists in all human beings, and it's critical for life. It's just that men and women live with different levels of testosterone. So we do have data on testosterone in women, and this study that I'm going to talk about today is a great example of that. So let's get into it. This study is called The Effect of Transdermal Testosterone Therapy on Mood and Cognition Symptoms in Perimenopausal and Postmenopausal Women. And in this study, they looked at 510 women who were already taking hormone replacement therapy. 510 women. That's actually huge in terms of studies looking at testosterone in women. So this is going to be a powerful study because it has a large sample size. The average age of these women was 54. 66% of them were postmenopausal and 34% were perimenopausal, meaning they were still having their periods, but they might be getting irregular as they approached menopause. So now we know that the results of this study will be applicable to both women who are in menopause, their periods have ended, and those who are approaching menopause in that perimenopausal transition when so many women are experiencing symptoms, but their periods haven't completely stopped yet. And all of these women were using some form of hormone replacement therapy, some form of estrogen combined with a progesterone, possibly if they had a uterus, either oral micronized progesterone or the Mirena IUD, which is an IUD placed into the uterus to release local progesterone there. But even on this hormone regimen, these women were still complaining of both low libido and some other mood or cognition disorder. That could be things like depression, irritability, anxiety, difficulty with memory or thinking of the right word. So these were patients taking hormone replacement therapy, but not feeling full relief of certain symptoms. So in addition to their hormone replacement therapy that they were already taken, these women were then given a testosterone gel or cream, and they used it for 4 months. And then they studied how their cognitive and mood symptoms did both before and after adding the testosterone therapy. So how much testosterone did these women actually receive? Well, they were able to use an option of one of 3 gels or creams, and it was up to the patient and provider discretion. But on average, they all got about the same daily rate. It was about 5 milligrams per day. And before they started, they divided the women with symptoms into 2 groups. Some of the women had cognitive symptoms. These were symptoms like feeling tired, issues with memory, and issues with concentration. And the other group of symptoms were called mood symptoms. And these were the ones they listed as irritability, depression, anxiety, crying spells, and low libido was in there as well. So we've got 510 women already taking hormone replacement therapy, estrogen with possibly progesterone, who still complained of low libido and one other of those mood or cognitive symptoms, and they added testosterone to their regimen for 4 months. And at the end of the 4 months, all 10 symptoms that they look at significantly improved after just 4 months of adding testosterone therapy to their plan. And they showed that the mood symptoms improved more strongly than the cognitive symptoms. The mood symptoms improved by 47% overall, and the cognitive symptoms by 39% overall. They noted that the symptoms most likely to improve were loss of interest in things. 56% of women reported improvement there. Crying spells, 55% of women reported improvement there, and loss of interest in sex or libido, where 52% of women reported improvement. Over half the cohort reported improvement in symptoms after just 4 months of testosterone use. And the study showed that both mood symptoms and libido improved at a similar rate. And that makes complete sense because libido is simply a mood disorder. When we are in a good mood and our stress levels are low and we're generally feeling well, we tend to have a higher libido. It's much easier to get in the mood for sex. But when our mood is depressed or irritable or we're stressed and our cortisol levels are higher, it's much more difficult to have a powerful libido. So it makes sense that as testosterone improved mood overall, that libido also improved to a similar degree. So overall, I think this was a really positive study. But when you read medical literature, it's really important to know if the data you are looking at is going to apply to the patient you want to take care of or to you as the listener. So let's look again at who they included in this study as their patient group. It was women who were in the perimenopausal or menopausal time, and they had to previously been taking hormone replacement therapy for at least 3 months. So we need to know that the results of this study are best applied to women taking hormone replacement therapy, not men, and not necessarily women not taking hormone replacement therapy. It doesn't mean testosterone will not have the same effect in women not taking estrogen and progesterone. It's just that this study can't confirm it. And it specifically applies to women taking hormone replacement therapy who still felt that their mood, libido, or cognition symptoms were not fully improved. And very important in the method of this study was that they did not change the dosing of estrogen when they added the testosterone. So we don't want to move too many levers at once in a medical study. We want to change one thing. In this case, it was the addition of testosterone, and see what moving just that one lever does to symptoms so we can know that it actually relates to changing that one variable. And finally, what I think is a real strength of this study is that they used validated symptom questionnaires to have the patients rate their mood and cognition symptoms before adding the testosterone. And then they repeated those same validated questionnaires 4 months later when they were done using their testosterone. Mood and cognition symptoms are one of the hardest to objectively measure. It's really difficult for my patients to quantify these symptoms because the most common thing I hear when people come to see me is, I just don't feel like myself anymore. This is not my normal self. I'm not irritable. I'm not short-tempered. I'm not snapping at everyone. I'm not having difficulty with memory. This is not my norm. It's something fairly difficult for them to quantify. But the validated symptom questionnaires that they used in this study asked the patients specifically about different mood and cognition symptoms and had them rate them on a scale. And then after using testosterone therapy, the patients rated them on the same scale so we could have a comparison. And I can tell you that in my clinic, where we use a ton of testosterone for both men and women, one of the most common things we hear after beginning testosterone therapy is, I feel so much better overall. I'm more like myself. And as I said, that's difficult to quantify, but the patients know it when it happens. So to summarize this, cognition and negative mood symptoms were highly prevalent in this real world cohort of 510 perimenopausal and postmenopausal women, despite the use of estrogen with progesterone for at least 3 months. Transdermal testosterone therapy was added for 4 months and was associated with significant improvements in all mood and cognition symptoms that they measured, including libido. They showed reductions in both symptom frequency and severity, and overall mood symptoms improved more than cognition, with 47% of women reporting an improvement in mood and 39% of women reporting an improvement in cognition. And my own personal take on that is this was a fairly short-lived study. It was only 4 months. My impression, and this is just my observation, again, from treating tons of patients with testosterone therapy, is if you use that testosterone therapy much longer than 4 months, that would be when you could start to see even a higher rate of improved cognition symptoms, memory and concentration and things like that. So even in a short study, I think these findings are really significant and powerful, but it would be great to see this study extended longer and retesting those women with the validated questionnaires after 1 year or 2 years, because things in the brain do not happen quickly. Change happens slowly there, and it would be great to see where they are over a more substantial period of time. So the authors suggest that the addition of testosterone therapy to current hormone replacement therapy may negate the need for physicians to go higher on the estrogen levels to continue to treat mood symptoms. And that's a great statement because there's a lot of worry about how high should we go with estrogen replacement therapy. And if it's done correctly, we shouldn't have to go excessively high. However, we do want your estrogen levels to be high enough to protect your bones, protect your brain, and protect your heart. But more estrogen may not necessarily mean better mood and better cognition. Where the missing piece may be is adding some testosterone at that time. So real world, what does this mean for you? If you are a woman in perimenopause or menopause thinking about possibly using testosterone therapy, well, I will give you my opinion on adding testosterone, which is a bioidentical hormone that your body has made for 30 to 40 years from your ovaries or your testes if you're a man. And that once you reach your 30s and 40s, begins to decline in production and continues to decline throughout the rest of your life. Replacing this natural human hormone that your body is no longer making in optimal levels seems like a very reasonable and safe thing to do. We do it all the time with thyroid hormone. We know that the thyroid creates a life-saving hormone. It actually produces two types of hormone, T3 and T4. These are critical hormones for quality of life and health and reduction in mortality. And if someone has their thyroid removed, meaning they're never going to make those thyroid hormones again, we give them thyroid hormone replacement at that time and for the remainder of their lives. We would never consider taking them off it. I don't look at testosterone, estrogen, or progesterone any differently. These are critical human hormones. And when your body stops making them due to age and disease and maybe radiation, or maybe you've had surgery to remove your ovaries, when a critical human hormone is no longer being made, it seems completely reasonable to replace that hormone for the remainder of your life. And studies like this are showing that not only do they improve quality of life and symptoms, but there are other studies that potentially lean towards showing us that they reduce mortality and they reduce things like cardiovascular disease, heart attack, and stroke. So it's crazy to me that the population as a whole doesn't see this as something kind of common sense. What's the worst that can happen? We give you back a bioidentical hormone that your body makes anyway, and you don't feel any better. Fine, then we can stop it at that time. But chances are fairly high that you will feel improved symptoms with minimal to no risk, possibly some side effects. Side effects, remember, not dangerous, just things that we expect to happen based on the structure of the molecule. And if you do feel better, great, continue on with the hormone. We don't want the levels to get too high where the side effects might be too high, but we want it to be at a level that is improving your symptoms and improving your quality of life. But for a lot of physicians, there's so much stress and angst about using testosterone in women because it's an off-label use. And the FDA hasn't specifically approved it for the use in women for libido or any other symptom. But again, that doesn't make sense to me either, because every physician in every single field uses drugs in an off-label use every single day. Birth control pills are probably the most common example. OBGYNs constantly prescribe birth control pills. Over 50% of the population will have used a birth control pill at some point in their life. And most of them are not using it for the FDA-approved reason of contraception. That is pretty much the only thing that birth control pills are FDA approved for. There is one birth control pill that is specifically also FDA approved for acne. But birth control pills as a group are constantly prescribed for things like heavy menstrual periods, PCOS, acne, and the list goes on. And OBGYNs wouldn't bat an eye at giving a patient a birth control pill for any one of those off-label uses because we know that they work, we've seen that they work, and we know the side effects of the birth control pills and how to manage them. But for most providers, it's much harder to get them to prescribe testosterone, which is our bioidentical hormone with very low risk of side effects if safely used for any indication, even though we know how it works, we know what the positive outcomes are, and we know what the side effects might be and how to manage those. And what if you're already taking testosterone, but your libido is not improved? Does that mean that testosterone does not improve libido? Absolutely not. Libido is much more complex than just the addition of testosterone. Testosterone is a critical part of libido in both men and women, but by no means is it the only component of libido. So if you're already taking testosterone and maybe your libido has improved some, but not enough, or you didn't see any improvement, keep working on it. There are so many other things for your provider to look at. Are you having painful sex? Is sex feeling dry? Is the vagina irritated? Are there relationship issues? Are there other mood issues that have to be dealt with? Are there tight pelvic floor muscles? The list here also goes on. And a sexual health expert should look at all of these things rather than just giving testosterone alone. And then if it's not helpful, saying, well, I guess your libido didn't get better on that. That is just one part of the puzzle. But today, if you're looking for data on the use of testosterone in women, it exists. It's out there. This study is out there. I'll link it in the podcast description so you can take a look for yourself if you would like. You can print it out. You can bring it to your provider if you're interested in trying testosterone for libido or mood disorders, or for any of the other benefits that testosterone gives you. I love talking about this with you guys, and I hope you'll be back to listen soon. Thanks so much for listening to today's episode. No information from this recording is intended as a diagnosis or treatment for any disease. If you are enjoying the show, please subscribe so you don't miss any of our exciting episodes. And we love to hear from our listeners and would be grateful for your positive review. We'll talk next time.